Senator Wyden.
Thank you very much, Madam Chair. And Madam Chair, I'm especially appreciative of the fact you cited those numbers at the beginning of your opening comments, because they're certainly encouraging. And I think you cannot fudge those numbers. They're indisputable. I'm glad you cited it. I also want to thank all our witnesses. I've had a chance to work with all three of them. It's been an excellent panel. Let me start with you, if I might, Mr. Nichols, because of your comments on transparency, and you noted the fact that Senator Grassley and I have introduced this legislation to, for the first time, open up the Medicare database so that all over this country we could see, in effect, what Medicare was paying for various kinds of services, and we could also learn about a lot about claims, the utilization rates, for example. Why does one area, in effect, bill more for MRIs or hip replacements than another? And my sense is that the day you publish the Medicare database in this country, you would have, in effect, a new baseline for health care in America. You know, all over the country, if somebody held an employer health plan, for example, or had an HSA, Mr. Antos referenced that, people would look at what Medicare was paying in their area for those particular services, and they would look at utilization, and they would start making that comparison and saying, why is what I'm getting out of sync in terms of costs or utilization? Is that pretty much your take of where you'd like to go in terms of transparency?
You know, what's been fascinating to me, Senator Wyden, is how similar actually your vision is from what Senator Johnson just described, and that is, how do you make a market work? And I don't know how you make a market work without better transparency, and the Medicare data facts would be huge improvements over where we are today. I would also just add, what you really want to do is to bring the Medicare data together with the private sector data, and that's what some of these states are doing in these all-payer claims databases, because then precisely you can compare what Medicare is paying. You can also look and see, what are we in this community spending more on? Are we out of whack with other places? No one knows that now, and you can't know it without access to data. So I am totally in favor of using data to add transparency.
Well, thank you. And I want to note, apropos of the kind of coalition that's out there, some of the most progressive voices in American healthcare want to do this, as do some of the most market-oriented individuals. So I appreciate your making that point. Dr. Pavel, a question for you on chronic care, because you have really been one of the authorities on this with respect to primary care. I think the debate really starts, and it's a point that Senator Whitehouse has touched on with respect to the delivery system, is that Medicare in 2013 is very different than Medicare when it began in 1965. We've got a lot more cancer, we've got many more strokes, and we have a much higher rate of diabetes. This is essentially more than 80% of the Medicare spending in the country. So my question to you is, and Senator Isaacson has been particularly helpful in this area, but there are a number of Democrats and Republicans who want to work on this. Is it your view, apropos of care coordination, if the incentives were changed so that nurses, PAs, those who specialize in geriatric medicine were paid to specialize in effect, coordinating chronic care, that could help give us a downward push in terms of holding down Medicare costs, while, as Senator Isaacson says, beefing up the quality of care for those who are the most vulnerable while reducing costs? Do you think that's plausible?
Thank you for that question, Senator. It's definitely plausible. It's even less complicated than that. You may not have to ask nurses or physician's assistants to specialize in this. This is actually what most of us are trained to do, but in our current fee-for-service system, we actually can't do this. If I want to coordinate care outside of seeing someone in my clinic, it's increasingly cumbersome, and quite honestly, the incentives are not there to actually allow for that. So you're correct in that some way to coordinate care better for patients with chronic conditions, and actually engaging, getting back to the point that both you and Senator Johnson made of allowing consumers to be true consumers in healthcare. It certainly applies to Medicare beneficiaries with chronic conditions. Most of my patients have 4 or more conditions and are on 6 or more prescriptions, But it shouldn't be that I have to wait till they come into my office in order to start dealing with those problems. From the time of enrollment at Medicare, we should be engaging. And we've started that in the Affordable Care Act with the Welcome to Medicare visit, but we can certainly specialize that for patients with chronic conditions.
My time is up, but I'm glad you made that point. And again, I think this is a unifying, point. We just did a chart, an analysis to look at how much of the country, particularly rural areas, and Senator Sessions and I have talked about it, really has few, if any, doctors. So if we were to do what you're talking about with respect to chronic care, is build in that bigger role for the nurses and PAs, again, I think this would produce support across the political spectrum. Thank you, Senator Murray, Chair.
Thank you.